This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Today we have Dolphurs Hayes, who's one of our esteemed first-year fellows, just finishing up his first year. He originally went to Morehouse for medical school and then MGH for residency, and we were lucky enough to keep him here at Emory for fellowship. And he is going to be speaking to us today about sports cardiology. It's all you, Dolphurs.
All right. Well, thank you all for having me today. It's been a pleasure being here for the last year as a fellow. A lot of learning has took place. So for the people that I haven't got a chance to meet, again, you're Dolphurs Hayes, and first year clinical fellow going into my second year. But right now, one of my interests, which it seems like it's been persistent, is sports cardiology. So that's why I will be speaking to you all about it today. So to give you all some information on it so that you all can use it also in your clinical practice. So I titled my presentation "The Field of Sports Cardiologists, a Generalist Guide," just so you can give some basic frameworks that you can use throughout anybody's like day-to-day practice. Because as we are starting to see aging in the population, more people are having some of these issues that they were athletes before and now starting to have some sequelae of that later on in life. And I'll get the slides to move here. So these are the objectives. I added like two more on here. So the big thing is just to identify various cardiac adaptations that occur in athletes. We'll also go through some of the screening guidelines in the US and also over in Europe to see like the contrast between the two. We'll also look at some of the physiologic cardiac remodeling that takes place and how can you distinguish that from a pathologic response. Also looking at some EKG patterns, which is very important to be able to understand what is normal when you see an athlete versus some abnormal EKGs that should definitely raise a red flag. And lastly, just how do we use different cardiac modalities to distinguish pathology, like MRI and just looking at your genetic screening, things of that nature, and how we go about that pathway. So to give you all a little bit of background about sports cardiology, like when did this come about? So it dates all the way back to the 1930s, when some of the physicians around that time, they started to coin the term athlete's heart. And it's all probably in response to Einthoven's creating the ECG back in 1902. So you can see that's almost a 30-year gap in time. So the ECG started developing, get more, put in more of the hospitals. So more of the physicians and cardiologists at that time started to get used to what they would see. And what they'll start to notice in these athletes is these LVH patterns, things that we starting to pick up now easily because we have a lot more practice. They start to notice in the athletic population, they all start having these distinct features. So that's when it start, like the thought process start coming in that maybe something is happening different in athletes versus the general population. Fast forward 50, 60 years, people started to correlate these sudden cardiac death events in the athletic population and started to think about, do we need any like screening guidelines? How do we make sure that these people are safe in their activities? What could we do? So over in Europe, they started to create guidelines. We'll talk about one of the landmark studies that caused that. And even in the US, early 2000s, after these things started to come out, we actually created our guidelines of how we go about it. And fast forward now to today, you actually start having sports cardiology fellowships starting to pop up across the United States. Really only like mainly two, I think, official now, but a lot of are the merged now. One of the places at MGH where I did my residency training. So that's why I was able to get a little bit more exposure in the sports cardiology field before I started here. So let's first talk about the incidence of sudden cardiac death. I think this is a big one because most people look at these numbers and like the incidence of sudden cardiac death is 1 in 80,000. So why should we put that much energy in something that you're not really probably saving a lot of people because it doesn't happen more or happen more frequently. So the key thing I put here beside it, as you all can see, is the incidence of fatal commercial plane crashes. And you see that's 1 in 11 million, which is a very low number. And these things have something very much in common between each other and why I put them here. While the incidence is very low, their impact is very, very high. So for instance, anytime we get on the TV and we see a plane crash, especially it's commercial, and people lose their lives, innocent people, it goes all across the news outlets. It affects millions of people. Even the recent crash that happened in DC, they've seen all the flights decrease. immediately after that because of all of the stress and fear that's elicited when some of this happens. And the same thing actually happened in athletes. When you see a basketball player drop dead in the middle of a basketball game in high school, it raises questions like, will that be my kid next? Or could that be me? Is it something wrong with my heart? So having that knee-jerk reaction, I think, is why this field is starting to grow. Even big celebrities, LeBron James' son, Bronny James, having a cardiac arrest event while he's practicing for his college basketball team. So things like that happening, starting to raise more awareness and why this field is starting to emerge more and more. So now we can kind of pivot over to some of the common causes and risk factors for sudden cardiac death. So the most common cause in our young athletes, these are like teenage, early 20s, is HCM, hypertrophic cardiomyopathy, which we are starting to get a lot more familiar with that now. And more in our veteran population, whenever we say veteran athletes, we're talking about people over the age of 35. So CAD is something that's starting to emerge a lot within this population. Maybe they exercise very frequently in their early years, start to develop some plaque maybe because of family history, and then try to continue those activities later on in life and then end up having MI. So something to definitely look at in there. But interestingly, males have been affected tremendously a lot more than females. You see about 90% of cases are male-related. It could be some bias in how many males do sports versus women, so that could also play a part, but I think that's still a pretty startling number of being 90% dominant. And right now, our highest risk group is our male basketball players, and we'll go into why this is the case or why we think it is the case. It's still like an evolving field. But right now, like 1 out of 5,000 cases still occur with basketball players. And I just gave you that one example, even with Bronny James. We had plenty of other basketball players dropping dead, having cardiac arrest events. So why is that? So that'll kind of pivot us over now into our the type of remodeling that takes place with the heart. So if you just focus your energy down here, that normal structure of the heart. So these are general population. People just play like golf from time to time. You do recreational sports maybe 2-3 times out of the month. You should have a normal heart. Your RV shouldn't be dilated, LV. And I got this picture actually from Megan Wasby. She was one of my mentors at MGH that she do a lot of sports cardiology. So they were able to create this picture, which is, I feel like is amazing. So if you look up your y-axis here, you see as you start to increase your static load, so these are more of your resistance training activities, you start to get that LV hypertrophy. And this can happen in a variety of sports, but because of course, the most notable weightlifting, because you're actually physically pushing a lot of resistant weight against you all the time, football players. But not all football players are the same, because a lineman, if you all just remember what they do every play, they're pushing, exerting themselves, trying to push the defender in front of them constantly all game. So it's a lot of resistance training versus a wide receiver doing more endurance running long routes. So different remodeling can take place in that. And even field events and track and field. I think probably most of y'all in here know that I was an athlete in college and I was a pole vaulter. A lot of pole vaulters don't do a lot of endurance training. Me, myself, I did a lot because my coach unfortunately made me run with the track and field team for conditioning. So I may have had more of a mixed picture, but a lot of them don't. A lot of pole vaulters do a lot of weightlifting, working on their core and then doing the vaulting, which again is a lot of resistance constantly, which can kind of give you more of that concentric LV hypertrophy pattern. So if you now pivot more over, so say you are still getting that resistance, but now you added more endurance. So now you think about your dynamic load. These are people at these high preload states. The cardiac output is very high because they're doing a lot of like endurance training. So you will typically see that in a rowing athlete, cycling. And you can just think about rowing in your brain, how they're pushing and pulling. That's the resistance. But doing this over long periods of time also give them endurance. So you see they start to have dilation of the RV, LV, and it's not included in this picture here, but you also can start seeing some left atrium enlargement, also right atrial enlargement. Just because that high output, the heart starts to stress and you start to get some of that eccentric. So of course we have a difference between the concentric, which is more thickening, going more towards the medial piece versus now stacking on top of each other, now getting that eccentric hypertrophy. And then you can go on to now the more eccentric LV remodeling. And if you pay attention to the different LV chambers here, you see this one down here isn't as thick. You don't have that as much as the resist that static load. And these people can have just more larger hearts. That their chamber size is definitely a lot wider here, just looking at the internal diameter between these two. And definitely in that mixed group, you start to see more of that right atrial and left atrial enlargement. Also, you get that RV dilation. But as we'll start to see throughout all these things when we do further testing, it still could be normal. But what happens when you turn 60 or 70? It can also cause some problems later on down the road. And I included these last 2 points in here, the atrial enlargement, which I talked about, more common in your endurance and mixed sports. But the RV dilation and the mild dysfunction that you'll see called on some of the echo is actually interesting because we know the RV, when it remodels in a different way than the LV. So the structure of it starts to kind of like change. Not only is it dilating, but it's changing access. And you know, when we're looking at echo, we measure TAPSE. So we're measuring the up and down velocity, but what happens when it changes off axis? So now, when you're at the sonographer and you're reading, you may see, oh, the TAPSE is reduced mildly, when actually it may not actually be reduced. It's just, it's off axis, so you're not catching how the RV is actually squeezing. So, but you will see it commonly called in a lot of the well-trained endurance athletes as mild RV dysfunction. So it's something just to put in the back of you all's mind, things that could come up. So now we'll pivot over into some of the current screening guidelines that we have. So in the United States, the AHA and ACC, they created a 14-point history and physical. But the most prominent point in this is that there's no ECG attached to ours here in the US. Still to this day, even though other societies have started to adopt this, we decided to keep that off. And I'll talk to you about maybe why that's the case. And the guidelines were actually created for us in 2007, and they had updates in 2014, 2021. So slowly they started to make some changes, but still to this day, we don't have an ECG attached to it. But over in Europe, as we all know in medicine, they're usually a few steps above us when it comes down to implementing different strategies into healthcare. So they now require ECG. So not only are they doing history and physical or pre-participation physicals, they're also getting EKG on all these athletes to see if there's any pattern. And I'll talk about why they actually did that. And our Olympic committee, ECG is a part of it, which makes more sense. They're doing these more strenuous activities, so they want to know. So the EKG, targeted testing, even in our professional leagues. So like Dr. Jonathan Kim, being able to work with NBA, NFL, you see this. They get a lot of ECGs, they get a lot of echoes. They want to make sure before they pay these people $50, $100 million that they're actually okay. So I guess that part is understandable why they would do that. So here is actually the current screening guidelines we have in the United States on how we go about looking at athletes. So it's broken up into 2 parts, your history, which counts for 8 points, and your physical, which counts for 6 points. In your history, most of the things that we ask a lot of our patients coming in. Do you have any chest pain when you're exercising? Have you passed out before or almost got lightheaded? Like excessive exertional dyspnea. So you're conditioning with your teammates, but you feel like you're just constantly getting this chest pain. Have anybody ever told you you have a heart murmur, elevated blood pressure? Somebody told you you couldn't play. And of course, at the end, just more family history, like sudden cardiac death, things that you will kind of think about. And then lastly, now looking at your physical exam. And the big part of this is kind of just looking for like morphology, things that will stand out that would suggest like a Morphans type picture. Do they have a murmur? Looking at their pulses, into the coarctation or anything that could be potentially causing this. And if you score any points on this test, you move on to the next step and get yourself an ECG. So it's not like the Chad Bass score or anything where you add up points. So, oh, you get over 3 points, now you go on and get further screening. But ours here, even though it says the 14-point, if you score any point on this, you now warrant yourself a further workup before you go on to play a sport. So here I included like the big landmark trial of why Europe ended up creating the ECG and putting a part of their actual guidelines versus us. So It started back in 1979, so they titled it "The Trends in Sudden Cardiac Death in Young Competitive Athletes" after implementation of pre-participation screening program. So that's just a long-winded saying they wanted to see if without doing an ECG, what's the rate of sudden cardiac death? But if we put an ECG attached to all these physical, what would happen? So what they did, it took a population of people from the ages of 12 to 35, and they had a ton of athletes, about 33,000 per year. And it was done in the Veneto region in Italy. So there was a lot of conflict with that. Like, is it generalizable over here to the United States because it was done over in that region? And what they did, it was a prospective observational study. It was done for 25 years, so a very long time. So they was able to collect, of course, a lot of data from 1979 all the way to 2004. And as I mentioned, the study goal just looked at the sudden cardiac death rates between these two. So how they did it, it was actually pretty unique. So through the first 3 years, they did the pre-screening process. So this was just a way where they did no ECG. They just kept it the exact same. People came in for the sports physicals, they asked them the questions, but it wasn't it wasn't mandatory unless something high risk showed up. So they went through and then they did a calculation on what was the rates of sudden cardiac death. It came out to be 3.6%, which is overall low, but it still was significant here. But as you pivot over into your early screening time, for the next 10 years, they did ECG. It was now mandatory. But during this time, they were actually learning how to interpret the EKG, because just doing the EKG and the people are not trained to look at it, you still may have a lot of false positives. People being stopped in sports, not being able to do things because they're seeing something abnormal that they weren't used to seeing. So not only were they doing the ECGs, but they were actually training physicians to get more adapted to what they're seeing here. So this late screening process is actually where most of your significant value came from. This is when now the physicians were well trained at looking at ECGs and how to interpret normal versus abnormal. And if you pivot over here and look at these results, you can see how this impact happened. So as I mentioned before, it was at 3.6. After the ECG was implemented, it went down to 0.4. And that was equating to 89% relative value risk reduction, which is pretty significant. And what we've seen during the early screening time, it was still pretty significant. It was 0.56 reduction, but the late screening, as you can see, that p-value is very low here, went down to 0.21. So it emphasized to them that not only should we be doing the ECG, but I think the most important factor is having people that's trained in the area to view it. Because what's the point of actually doing it when you can't understand what you're seeing and now you're not implementing the right strategies? Right? So this is a little guideline I just kind of put together. Dr. Kim, I don't know if he'll fully agree with it, but I think from a generalist standpoint, these are a framework that you can go through to make sure you kind of hitting all the points. So you, of course, start with your 14-point screening. Anything comes back positive, that prompts you to get an EKG. And from here, based on the patterns that you see, if it looks overall benign, you can stop here. But if it doesn't look, something is abnormal or something you're sure about, you would now go on to an echo. And we'll talk about the things that you could potentially see on the echo that can give you some type of indication. And after that, you can now move on to a cardiac MRI. That's if anything is still not pieced together. And as of right now, if you still need questions answered, then you would go on to your genetic testing. So you can notice that the genetic testing is not all the way in the front, not yet. Maybe it will change over the next 10 years as more data is starting to come out of screening people from a genetic standpoint, but as of right now, we don't have that. More of a last line. So now let's kind of talk about some of the EKG patterns that do not warrant further workup. So the more easier things that we probably all see is that asymptomatic sinus bradying. That athletic person comes into your office with a sinus brady in the 40s and they're completely asymptomatic. You can even have some of your Olympic athletes walking around with sinus brady in the 30s, completely normal. Other things that you can see is our first-degree AV block. And that just due to that high vagal tone that these athletes have, they have really pretty much no sympathetic activation. So the AV node just gets very slow and sluggish, so they will have a PR prolongation even up to 220. But the key thing with them, if you exercise these individuals, you'll actually see that the PR interval disappears. So now they don't even have first degree AV block, kind of pointing to the fact that they're just at the rest state, and that parasympathetic flow is what's causing that AV delay. Also, biatrial enlargement, what we talked about in the beginning with the cardiac remodeling process, more in your endurance athletes, they will have atrial enlargement. That could be normal. Junctional braiding, if you have a sample case of what we can look at later to see why their sinus rates are so low to the point where their junction was actually higher. So at rest, these people will walk around with junctionals and be completely fine. And then your LVH criteria, some of these people that have the hypertrophy, is mainly what we've been seeing, the so-called Lyon voltage criteria, where you can actually get it versus like the Cornell. So in your athlete population, you would probably look more into that field. If you don't see it in the Cornell criteria, you can actually meet it from this angle. So a big one I think is very interesting is the African variant, sometimes it's called the Black variant in athletes, which has been picked up over the last decade of what is this? Because if this person walks into your office for sports physical, you will probably get very concerned and tell them they probably shouldn't play whatever activity or whatever event they're doing. You probably shouldn't do it until you get further workup. So I learned about this actually in my last year of residency when I was rotating the sports cardiology clinic, and we had a black soccer player in there, and the team, of course, they didn't want to pay him any of his millions of dollars because they seen this pattern. But Dr. Aaron Baggish was one of the physicians that worked there. He immediately saw this and like, he's fine. And I was thinking, I'm like, what are you talking about? So let's look at some of the key things that happen. Of course, this circle here, what you can see is some of the T-wave inversions. It mainly just goes to V1 through V4. And I was looking at why that takes place. And it seems like in people of African descent and like African and Afro-Caribbean, when you have that repolarization, the potassium channels start to act a little bit different. They're expressed in different ways. So it can give you that abnormal pattern there. And the other key characteristic is right preceding it, you have this convex ST elevation. That one should give you more like indication that it's the variant and it's okay. Now, if you're seeing ST depression, that'll be a different ball game, something that we should not see. But it's having that ST elevation followed by that T-wave inversion only up to V4 is more consistent with the pattern. And let's say you were a little bit even more confused on, is it? You can now start looking at other characteristics on this EKG that will point you to maybe this is a well-trained athlete. Look at the LVH criteria. If you use your so-called Lyon criteria, V5, V6, look at your S-wave here, you meet criteria. You can look at the rate. We're like right borderline at 60, maybe going right into like the upper 50s. Also consistent with sinus braiding. And you can even look, I know this picture's not the best, this person even have first degree AV block that you can call on here. Again, all pointed to like high vagal tone, cardiac remodeling in the sense of that LVH. So something that you could see that actually is normal. Now, this picture may not be the clearest, but this pattern, what we actually probably see in some of our patients here, just in clinic and everyday life, this early repolarization pattern. And right after that, you can also see that concave ST segment elevation. And usually it's more pronounced over here in the V4, having that J point elevation with the ST. And I was looking at this, about 25 to 40% of athletes, depending on which source that you look up, will have this pattern. And again, it's located, it's the main things looking at the repolarization and what happens during vagal tone. Because your epicardium, endocardium, the repolarization, what happens in these athletes, it starts to differ. So the epicardium starts to repolarize faster, the action potential is shorter. So since this happened at different times, it creates a gradient. And therefore you have this elevation that's seen kind of widespread throughout. So another pattern that you could see that could be completely normal. And they studied these populations of seeing these people with these abnormal EKG, even the African variant, and they did echo, cardiac MRI, and they're completely normal. So again, a lot of research has been going into actually justifying why this isn't a big deal. Next thing is our juvenile T-wave pattern. So with this one, Dr. Winger actually pinpointed this one out to me when I was at the Grady, my Grady Consults rotation. But in teenagers going up to like age 19, maybe you can see it persisting up until 20 years old. You can have, again, those T-wave inversions, but this one mainly through like V1 to V3, kind of highlighting the RV. Because what happened is with kids and teenagers going over into adulthood, you mainly have an RV predominance to your to your cavity, to your ventricles. And as we get older, your LV starts to take over more and more. And as it becomes more the dominant chamber, you'll start to lose these T-wave inversions. So if you ever see the T-wave inversions going all the way throughout the whole precordium, that's something like a red flag. But just having it in this region here in somebody that's young as a teenager, again, looking at some of your hinting factors, look at the rate of this person, also sinus Brady, looking at the voltage, some LVH based on that Sokolov-Lyon criteria, things that would kind of point you to high vagal tone, most likely benign pattern. So now we can pivot over into some of the red flag ECG patterns that you can see in athletes that should warrant further workup. And you can say, hey, this is not normal. So your big thing is your T-wave inversion that go all the way throughout. This in your inferior leads or lateral leads, that always warrant investigation, because now you could be talking about your ARVC population. Looking at T-wave inversions preceded by ST depressions. I kind of pointed to that earlier in the presentation. So having any type of ST depression prior to your T-wave, you should work it up further. Just like we do now the wards, the pathologic Q waves, that still persists. So you have those, that's something that should kind of raise a red flag. Left bundle branch blocks, QT prolongation, and of course, Brugada. Anytime you see that, it definitely should raise a red flag for you. And just looking at the two most common things that, of course, that we're scared about is the arrhythmogenic right ventricular cardiomyopathy, your ARVC. So I include a EKG here so you can kind of see what happens in this scenario. So again, you see these T-wave inversions, but they're not just stopping at V3, like you can see in your juvenile T-waves, and not just stopping in your V4 region, like you will see in your African variant. It kind of persists throughout, all the way through. You even start to see some of the widening of the QRS complex. And most specific find that you can find here is your epsilon wave, that you can see that right hump here. And it's just letting you know there's some delayed RV conduction that's taking place. So that right there should start raising red flags to you that maybe there's something serious and I should go to the next step, get an echo, get a cardiac MRI to work this up. So these is a classic pattern that you can see in ARVC. The next one that we talk about a lot is HCM. So of course we know the different variants of HCM. You can have septal predominance, you can have apical predominance. The apical one, of course, is more rare, but that's the one that's easy to see. You have these deep T-wave versions go all the way throughout. But this, the one that I'm showing you all, is somebody that have more of a septal predominance to the HCM. So they're asymmetric. And the key thing that you can see here, they have the voltage criteria that you would think just could be just LVH, but you know they have these Q waves that's popping up. That should be your red flag that something is going on, because athletes don't have Q wave patterns in there. And really you can even see it, some of your inferior leads in this particular EKG is not there. And the reason, because in the septal region, since it's so thick, it takes most of the force away and targeted towards the V1, V2 region. That's why you even see that R wave there, and it pulls here from V5, V6, your inferior leads, and produce that Q wave variant. Whenever you see this pattern, Q waves in the lateral inferior leads, that should raise suspicion that maybe something else is going on. Maybe they're just not physiologic remodeling. Now we'll pivot over to our echo findings that you could see in athletes that can distinguish between mainly HCM, because I told you that's the most common cause of sudden cardiac death in the athlete heart, because they can mimic each other, because the LVH. So in the athlete's heart, the wall thickness usually is about 12 to 13 in males, roughly about up to 11 in women. But at HCM, it can go 15, 16, 20. So when you see stuff over 15, that should raise a little bit more suspicion that you're now in the HCM category. Looking at the hypertrophy pattern, is it asymmetric or is it fully symmetric? Being more symmetric kind of aligns you more towards that athlete's heart. The cavity sizes, I told you, more of your endurance athlete that are more mixed sports, they have dilation of their chamber, so it can get up to like 55. But at HCM, you typically don't see that. The heart is big, but the chamber size is actually, the cavity is small. But the most important thing on this slide, if you take nothing away from it, is the diastolic dysfunction, or diastolic function in athletes. They can have normal to even super normal. So not only is it thick, the actual chambers, but the elasticity and how much it can relax and recoil is what makes it normal to you. So you can do like tissue Doppler, your E prime looking at your lateral wall, it can go up to even 12 of these patients. And that could be like your key differentiating factor from an echo that lets you know that this is normal. This is most likely just normal physiological remodeling in the setting of training real endurance athletes. And the LA size I put here, for the most part, is normal depending on the activity. But of course, if this is a well-trained endurance athlete, you will see some LA enlargement, but mainly in HCM is often always enlarged, just given the fact that they have diastolic dysfunction to increase their LA pressures. So now moving over to MRI. So when would you use it? So you usually go this next step once that TTE, maybe of something indeterminate on there where it was some asymmetric septal hypertrophy, even though the diastolic dysfunction was completely normal. So you want to further investigate. Or is it in the gray zone? So that gray zone is between 13 and 15, where I told you like 13 and below is more the athlete's heart, but when you get above 15 is HCM. But what if somebody walk in your office with a 14 millimeter septal size? Now you're kind of in that gray area. So that's why people kind of pivot over to a cardiac MRI at that time. And just having poor windows for getting the echo. And the last thing is just they have a normal echo, but they got 3 siblings all have HCM. That's confirmed. You still had that high suspicion, you may want to go ahead and get a cardiac MRI to like fully rule it out. And the 2 big things that you want to look at on here is your late gadolinium enhancement. So we know in HCM, which is also a prognostic sign to see if these people need ICD implantation, most of them have scar. So they have a lot of LGE versus in an athlete that just have remodel, you shouldn't see any of that. So that could be a distinctive factor to kind of support your diagnosis that this is just physiologic remodeling. Also, you have more of your advanced quantitative analysis looking at T1 mapping and extracellular volume. And in this, the T1 mapper just lets you know how is that myocardium relaxing after they shoot the beams with the MRI. And typically at HCM, because of the infiltrate and how the muscle disarray is taking place, it takes a long time for it to relax, so it's elevated. And they also have a lot of stuff in the extracellular space, therefore kind of point you towards HCM as being as a diagnosis. And lastly, just looking at genetic testing. So with genetic testing, I told you once things, you went through your echo, you did your ECG, you got your cardiac MRI, but it wasn't like fully slam dunk in there. And you still have high suspicion, you can move on to a genetic testing at that point. Also, is they have just a lot of family history. What if I told you 2 of their brothers have it? It's 3 siblings total, and maybe you want to go ahead and just test that patient and make sure, do you have the same variant that your family do? So even though you could be early in the disease process, because we didn't talk about like the spectrum of when you catch the disease, they could be just have a septal thickening of 12. Diastolic dysfunction hasn't happened yet, so it can trick you from the cardiac MRI and echo. But if you go and get the genetic testing, you'll see, oh, you actually have the same variant as your brother. So you're high risk. I'll probably say more shared decision making that you probably shouldn't play this sport. And lastly, these are people actually that have the diagnosis, they have the criteria for HCM or ARVC, whatever it could be, but you want to do further risk stratification. So it's different variants, of course, HCM specifically. So the NYH7 variant, this one is associated with high sudden cardiac death. So even though you diagnose HCM, but they have this particular variant, not only will you tell them probably not to play sports, you'll also probably be talking to them about an ICD implantation. So it's still very beneficial to add on that genetic testing to just make sure nothing is changing there. And lastly, we'll finish up with just an example case that I did over at Midtown on my EP rotation over in April. So this patient originally presented over to Grady. So we'll kind of go through his clinical progression, and then I'll tell you when I met him at Midtown, what happened. So it's a 73-year-old gentleman. He has a history of persistent atrial flutter, who presented with chest and back pain. It was an acute onset over the last like 2 days. So he came to the Grady ED and he was found to be an A flutter with RVR, with rates up to close around 150, so like a 2-to-1 block. So given it was a typical pattern when they looked on the EKG, Dr. Toka went ahead and took him for the flutter ablation. And after he got the ablation, they noticed he was in his junctional bradyrhythm in the 40s. But he remained completely asymptomatic. He held his MAPS, his blood pressure 110s to 70s. And yeah, I say just maintaining well, but people started to get worried. You know, you got a 73-year-old gentleman in here in this junctional rhythm. We don't know how serious to take it. So they went ahead to see, okay, do you have chronotropic competence? So they went ahead and got a stress test, the exercise stress test, to see what happens. And what they was able to see, he was able to achieve 85% of his predicted heart rate, got up to 7.5 mecs. And even his peak heart rate was 125, but he had 1-to-1 conduction at that time. Right before they did this, they did get a TTE, just looking at his heart function prior to doing the ablation. And it showed he had a normal LVEF. He had mildly reduced RV function called on there concentric LV remodeling with a septal thickening of 1.2 and mildly LA and RA dilation, but no significant valvular disease. They couldn't do diastolic function testing on him because he was actually in flutter at the time, so it wasn't done. So given the overall concern still, even though he passed all the tests, they offered him a pacemaker still. He declined it. So they said, okay, what we'll do, we'll send you home with a Holter. So about 1 week into wearing the Holter, he got called by the reps that reached out to the cardiologist that his heart rate was now in the 20s. So they told him to go to the ED to get further evaluated. So he came over to Midtown Hospital where I was on call, and I got a page around like 9 a.m. And this is the EKG he presented in with. So again, these slow rates to like 30s, 40s, junctional rhythm. Of course, it's narrow because this is a junctional family. So he was stable. So I went bedside and talked to him and his daughter. He was very upset that he was there. Like, why are you in the room? Like, I just want to go home. And I was saying, like, are you any symptoms, any lightheadedness? Like, no, I don't feel anything. I never felt anything. So I was a little confused on like what we would do. Would we just offer this man a pacemaker? We even had the conversation about talking about it before I went in staff with my attendings. So I was overall a little worried, but again, he was asymptomatic. So I started diving a little bit into his history after I was talking to him a little bit further. Because he was a very slim guy, but he didn't strike me as like an athlete. But he now told me, oh, yeah, I'm a long distance runner. I run with the Atlanta Run Club. I do about 80 miles a week all the way throughout my adult life. I just stopped maybe over the last 10 to 15 years. Now I only do about 4 to 5 miles a week when I do a mixture of running and walking. So I was like, makes a little sense. And he said, yeah, my heart rates, even when I was in my 30s, around your age, yeah, I was in like the 30s. And I never had any symptoms. So this started pinpointing me back. I started thinking about my sports cardiology background of like how you could see these people you just didn't think about in a 73-year-old that presented over at Grady, got a flutter ovation. You kind of like mixing stuff together like, oh, maybe he had this flutter because of uncontrolled hypertension, some RA remodeling, something else process that took place. But just getting this detailed history from him, I was able to kind of piece together a bigger story. So we had him walk around for about 5 minutes after I staffed him, and my attendant told me to do that. And this is the EKG we got afterwards. So as you can see, he's still Brady, but now that sinus node is back. And most notably, he has first-degree AV block. As you can see here, he doesn't have the LVH criteria because, like I said, it could be more just dilation. He could be more that eccentric hypertrophy patient, but nothing there. But the good thing is, like I said, it was 1-to-1 conduction. We already know he had a normal stress test we did at Grady. So after taking all this stuff in consideration, we did decide to send this gentleman home and just have him follow with EP as an outpatient. I know sometimes you can still put a pacemaker in these patients because sometimes it can get very low, their rates, and it could eventually cause problems. So we did talk to him about that, but we felt a little bit more reassured that maybe there was something chronic for him. His sinus node just beats very slow, so his junction is actually higher than his sinus node. So it takes over from time to time and beats in the 40s. So that's why I'll finish up here. And then we can talk about any questions. But now just looking at veteran athletes, such as the patient I just took at, like what happens to these people. So over time, when you have that chronic left atrial enlargement, right atrial enlargement, sometimes with the dilation, you can have a little scarring that takes place. So the most common thing that we're seeing now is atrial fibrillation starting to develop in these veteran athlete population. In my patient, he was more of a flutter because he was more the endurance side. I told you with endurance athletes, you can see more of the right atrial enlargement as well. So junctional escape rhythms is another thing. Same thing with him. He walk in with this junctional rhythm, scare everybody, but in actuality, that could be just his baseline. And we talked about the first degree AV block and Mobitz type 1 that can actually develop as well with that high vagal tone and sinus node dysfunction. Just given you have that constant stress on your sinus node over time, you can have some scarring of it that they've now started to show in research that could cause you to probably need a pacemaker regardless of the matter later on. And that actually may be something that's happening with this patient. So that's why he's now followed intermittently with EP, just to make sure nothing changes and he do become symptomatic. At that point, they'll go ahead and probably potentially just do a leadless pacemaker, which I think a micro would be good for him. And that's all that I have for you all today. Thank you. If there's any questions, you all can send them my way.
Thanks, Dolphurs. One question I had was, which, this is maybe like an extension of the rest of your talk, is have the recommendations for exercise changed? Like if a patient is diagnosed with HCM and they get a defibrillator, are we still saying no, high level activities, or what are we recommending now?
I think that space is like evolving currently, but it's more like a mile workout regimen. And that's when they're using like CPET now, just to make sure these people are safe. So just kind of like somebody have an MI and you now put them in cardiac rehab afterwards. I think just having like, they allow them to do mild activity, but of course nothing strenuous. You wouldn't tell them to play like football after they have a ICD implanted. So I think it's still not definitely go back to your regular activity, but I think allowing these people to have some type of monitored mild activity, making sure it's safe, and then eventually allow them to exercise on their own once they feel like they're in a good place.
Hi, this is Francisco. And just to extend to that comment, I'm a soccer fan, and there's a couple of good cases that have happened where the athletes have collapsed and they have required actually an ICD, and it varies according to the country and the league that they play at. Some of the leagues have allowed to have them back wearing an ICD and play back in professional level. Other ones have not allowed that. So there's one case that was famous where the guy had to move out of the country and then play in a different country to be able to keep playing professionally soccer.
Wow.
So as Dolphurs said, it's an evolving field, I think, in most of the sports.
This is Robbie. I don't know if Jonathan's on this or not, but yeah, that's we've loosened the restrictions on participation for particularly for HCM patients significantly over the past several years, and it's a now sort of a shared decision-making process between the athlete, the institution or team, the physician, et cetera. So right there are multiple patients with HCM involved in high intensity competitive sports in this country and around the world, but all those decisions are sort of made carefully. In terms of regular exercise, yeah, we're pretty liberal these days with allowing folks with HCM to engage in recreational exercise. Should be limited by really just their symptoms. And I get, there's certain sort of special cases where we have to place a little bit more restrictions on patients, but by and large, studies have shown that it's generally safe. And then the other point I wanted to make, Dolphers, very good review. I enjoyed it. That landmark Italian study you discussed about EKG screening, just a couple, wanted to point out that there's been some criticism levied at that study over the years. If you'll notice, their baseline rate of sudden cardiac death was 1 in like 20 something thousand. So extraordinarily high. numbers that aren't seen really almost in any other database in the world. So that was probably part of that reason that study looked like it did so well. And then their end of study rate of sudden cardiac death, I think, went down to 1 in 250,000 or something like that, really low. So I think although the p-value was low, I do think probably a little bit of luck played into those results. I think has been sort of the consensus. So they started off with a atypically high baseline rate of sudden cardiac death in athletes and ended with an atypically low rate of sudden cardiac death in athletes. That being said, we all support, routine, at least for me, most of us support routine EKG screening for athletes, and it's a good idea, but I do think the Italians got lucky on that one. So, but good talk.
Thank you. Yeah, I saw a lot of that criticism when I was doing my literature review on it. And I did see that. I think they have a higher case of ARVC over in that region.
Yeah, that's sort of the thought, is probably that's why they were having such a high, whether it was luck or, yeah, they happen to have a pocket of folks that have a lot of ARVC in that part of the world.
Hey, Dolphers, this is Shannon from Grady. I have a question for you or anyone in the group. This is kind of outside the scope of screening, but I remember seeing an article in Fellowship that suggested that very high intensity athletes or like extreme exercise, it actually correlates with like increased morbidity and mortality in the long run, almost like there's a level of moderate exercise that extends life, but incredibly intense exercise could potentially have a negative impact in the long run. So I'm just wondering, for some of these Olympic athletes or really elite athletes, did you see that in any of your research, or just what's the trend for their like long-term outcomes compared to the general population?
Yep. So from my research, of course, my experience is limited. The mortality rates I didn't see was much higher, but the arrhythmia prevalence started to increase a lot. So the atrial fibrillation, atrial flutter, and the complications that come along with that. Because some of these people, their first incidents, because they may not even feel the flutter, may be a stroke, which can now, of course, affect their morbidity going forward. But I think that was the biggest things I've seen, because when you get to that point of having a lot of stress on the heart, you start to get more into that scarring and fibrosis that takes place in the chambers, therefore putting you at higher risk of now, instead of having this physiologic remodeling, now going more towards a pathologic. And the last thing, when I was in residency, it was starting to do research on actually the strain on that we do on on echo. We look at like the LV strain pattern. They're now starting to look at some of the RA strain patterns and LA strain patterns in these athletes to see, is it more like scarring? Are they having functional problems? So is it just dilated, but it's normal, or dilated and now is now dysfunctional? That would kind of pinpoint to now you pivoting more to pathologic, so we could kind of tailor some of your care accordingly.
Got it. Thanks.
All right, if there are no other questions or comments, we can wrap it up, and everyone have a great Memorial Day weekend. Thanks, Dolphers.
No problem. Thank you all for joining.
The preceding program is copyrighted by Emory University.